Thank you, Chaudhry Hassan. Now it's time for question and answer. If you have got any question, you can ask to our speakers, chairperson, and discussants. Any question from the audience? Okay.
My question to Professor M.J. Azam. So you did a primary PCI on 2 vessels, I think, and after 6 days you put a permanent pacemaker. So how did you manage these bleeding problems or anti-DRPT management?
Yes, it is very good question because DAPT is the major issue. So some right now, actually, what is the recommendation? DAPT, standard DAPT, you should choose standard DAPT. But once you plan for PCI, because we kept the patient in ecosprin and ticagrelor, so what we did actually, we wait up to 5 days. Up to 5 days, we continue ecosprin and ticagrelor. Then we observe there is no chance of reversion, so we stop the ticagrelor. Then we go for the 6 day. We did the procedure. After hemostasis complete, then we again start the day after procedure. We start again ticagrelor for up to 6 months, and we calculate precise depth score. It can be continue longer duration, so we recommend it for 6 months. Then again we follow up the patient. Then go for again depth score. Then we continue for it should be continue at least 1 year. Then we downgrade for at least single antiplatelet agent.
Dr. Ajam, the main question is during pacemaker implantation, how many days you will stop or hold the antiplatelet? Or you will do the pacemaker
I continue ecosprin.
With antiplatelet, you will do the pacemaker on the 7th day? Or do you stop antiplatelet for 1 or 2 days before doing the pacemaker?
Only I stop the ticagrelor only. I keep ecosprin continued. I stop ticagrelor on 5th day. I go for procedure 6th day.
Yes.
Then I again start in 7th day ticagrelor.
Actually, a lot of cases we also faces in our hospital. We usually continue ecosprin and clopid. And many patients with ecosprin 2 tablets, clopidogrel 150 milligram, we used to do the pacemaker without having more trouble. But for ticagrelor, it is very much difficult, or prasugrel, it is difficult to control the bleeding during procedure. So during first week, second week, it is very much disastrous. It may be disastrous if you stop any antiplatelet, even for single or 2 days.
Okay, any comment from Chaudhry Hafiz? Should we continue ticagrelor single?
No, so the recommendations are to continue DAPT.
DAPT.
Okay, so aspirin and clopidogrel are preferable because the bleeding risk is lower than ticagrelor. So do not change in the first month, even to single antiplatelet agent. There is no data to support ticagrelor monotherapy for the first month. Absolutely, the TICO study looked at it after first month of DAPT, and then you can switch to ticagrelor alone. That is being studied. But preferably, you need to continue both aspirin and clopidogrel if you're going to go for a pacemaker or anything. Of course, I don't think that there is less bleeding. There will be bleeding even with the clopidogrel, but obviously the surgeons they will take care of that with probably using some other material while doing the pacemaker.
While I do the device implantation, and especially if it is within 15 days of a PCI, you cannot stop any antiplatelet. That endanger the patient for an instant thrombosis. And so what I do use diathermy during making the pocket so that there is no oozing point. And after implantation, I put a pressure bandage overnight. Then the next day morning, I just remove it. And usually, most of the patients do not have any hematoma.
Yes.
Okay.
Dr.
And
Azam.
I have a question to Dr. Nasir Khan.
Yes.
Let us solve the
Okay,
issue.
I just
Dr. Professor Azam.
Yes.
Professor Azam, I want.
Azam.
Professor, I want to say, in old days, we used to wait for 2 weeks before implanting permanent pacemaker. Is it wise to do so early permanent pacemaker? in this case?
Yes, that is on issue,
Sir,
yes.
Sir, actually, if it is related to anterior MI, then usually the patient needs pacemaker. And if it is for RCA related complete heart block, then we can wait for 10 to 15 days.
So I have one question to Dr. Shandip.
Regarding,
Dr. Shandip.
regarding this issue, I do agree with Dr. Ramesh. What we are doing, continue both DAPT. And this is the mandatory for a person to take in a stand whether he will be able to continue dual antiplatelet therapy or not. And that is why we continue dual antiplatelet therapy. And I do agree with Dr. Jamil that during the procedure, only diathermy is essential, otherwise no problem. Thank you.
Just I would like to on point regarding the guideline, latest guideline, they didn't make any difference anterior and inferior MI. They give the same protocol 5 to 10 days. Wait for 5 to 10 days, whether it is reverted or not. If not reverted, go for pacemaker.
Actually, what
first
I
of all,
want
I
to
want
answer Professor Jahir sir, he asked, should we wait for up to 2 weeks, sir? I appreciate your approach because I just try to recall the study, but in the guidelines, they recommended 6 days and 2 weeks, there is no significant difference in terms of outcomes. So what we did actually, Ramesh rightly said, DAPT should be continued because it is multi-vessel, triple vessel disease. Why this patient has bleeding tendencies more. That's why we take the only ecospin continue, but it is not recommendation. It is just I apply my wisdom and try to tackle it, and I definitely use the diathermy and I closely follow up the patient. But teaching is that you should continue DAPT despite high bleeding risk patient, but you should take extra precautions for diathermy so that you can minimize the bleeding risk.
Yeah, so there is no need to stop the DAPT. And in the US,
Yes,
we don't
yes.
put the temporary, we don't put the permanent pacemaker. I usually find a EP guy who can do the pacemaker on the DAPT. So no compromise on this issue. And then you mentioned about the integralin. For the pacemaker and devices, we don't transition with a 2B3A inhibitors. For non-cardiac surgery or for other reasons, now we use the Canglilor as well.
So I have a question to Dr. Shandip. Dr. Shandip, your second case where in inferior MI that was previously stented.
Yeah.
Second case, can you remember the second case?
Yeah,
Inferior
one
MI
with the
RCA,
bare
there
metal
was,
stent,
you did
2002.
the rota first, then you did the IVL. So inferior, any case of acute MI, rota how much safe in acute MI, especially in when there is thrombus or ice are in the stent. You did the rota first.
So actually that case, the patient came
That
at
was
1
very
o'clock in the
difficult.
morning
Yes.
and my colleague tried to pass a balloon. The only balloon you could was 1.5, 1.25, they burst. Then you use a 2 millimeter that wouldn't expand. But at this time the patient had TB3 flow. So he rightly stopped. I think that was the right
Yes,
decision
yes,
to do because doing a rotablation at 1 o'clock in the morning, even I will struggle because the team may not be used to it.
Yes.
So patient was sent to a home, like sent to the ward with the GB2B3 inhibitors. And next day when he came, I tried to use the balloon again. It didn't go. So I switched to the rota straight away, did the rotablation and did the IVUS after that. There was a cracks, but still the balloon was not expanding because there was the calcium still there. That's when I used IVL.
Yes.
So it's a very rare case where I use rota and IVL in a primary PCI.
Yeah.
But that was a very unique case.
Thank
in
you.
fact, we present that case at the CT.
I like to ask a question to Dr. Nasir Khan.
Now, Dr. Shandip is here. If any question to him, then. And Dr. Shandip, you have presented very nicely bifurcation, calcified lesion with primary PCI. But one thing I did not understand regarding CTU and primary PCI. CTU with acute MI, how is it possible and what is
I
your...
agree because CTO will not give acute MI, but sometimes you could have acute on chronic occlusion.
CTO.
Someone who's got almost like a tight stenosis,
That's
calcified,
right. Near
which may
CTO. That
close
means-
off and
Yes.
can present. So, for example, the one I
That
showed
may be.
was a big thrombus burden. It
Yes.
behaved like a CTO.
Near total occlusion was
We-
there, and
yeah.
that was very much calcified and
Yeah.
very much difficult to cross, and that
Yeah.
may be. And another thing probably may be added, that is the primary PCI in graft vessel. Graft vessel with myocardial acute ST elevation myocardial infarction, that sometimes we face. We do not use usually any device, only crossing the wire, getting the site of the lesion, and give the stent. Only
think that-
we do it.
I think that's a very good point. With the graft, we do just a balloon angioplasty, sometimes DCB, establish a flow, then open the native right. I think that's the current practice, to open the native artery than the graft. Especially the graft looking unhealthy with ectasia, thrombus, we tend not to treat that in the long term. And one point I would like to make, I think there was a comment made that we deferred stenting. We don't do deferred stenting only in that big thrombus burden. Putting a stent, we will cause slow flow. It's only in that case we deferred stenting, but otherwise we stent at the same time.
Dr. Jamil.
I like to
Dr.
ask
Sandeep.
Dr.
Dr.
Nasir.
Sandeep.
Yeah.
I have one more. I have one more question to you. Thanks for your nice presentation. Suppose this not regarding your case. I am giving you a scenario. If I start a primary PCI in STEMI, but in a center with limited facilities where there is no facilities like your scoring balloon or cutting balloon or IVAS or IVL or ROTA. If I start, then I cannot go back. Then what to do? If I deploy the stent, it will be under-deployed and the chance of complications in future. But if I try to over-dilate, there is chance of perforation or dissections like this. So in that case, whether in the center with limited facilities, we should start primary PCI, or we have not enough time to refer to other centers also. So what can do in this scenario? If you can answer.
You mean the first case you said where there was direct stenting? Yeah, I mean, that was something which we were caught out. I mean, that shouldn't have been directly stented. I don't directly stent any of the lesion, even in primary PCI. But if you don't have these options, very difficult. In that case, luckily we had IVL. Otherwise, we would have used a OPN balloon with a high pressure and hoping that it expands without perforation. Yeah, I think these tools are very important, especially when we're dealing with calcified lesions. But my personal opinion is that if you establish a TIMI3 flow, you don't have to stent it. You can defer the stenting, especially if the lesion is complex. Maybe we can do it at a later time when we have devices and everything. So yeah, that's my answer.
Thank you.
So, can I ask question now?
Thank you. We are running short of time. It will be the last question from Dr. Jamil to Dr. Nasir Khan.
My question is, you recommended for DAPT beyond 1 year, especially the young patient. Now, the whole interventional cardiology world is trying to reduce the duration of the DAPT, especially to reduce the bleeding risk. And the stent companies are trying to make without polymer, biodegradable polymer to reduce the DAPT. But why you are recommending for antiplatelet, dual antiplatelet beyond 1 year, and what's extra benefit it will give?
Yes, thank you. Actually, there are some data of having the benefit of DAPT beyond a year. And like I said, it has to be selected case. Normally, we would not do DAPT beyond a year, just monotherapy, either with P2Y12 or with aspirin. But when you have a high thrombus burden, you know the patient has chance of having instant thrombosis even in future. Or if you put a stent in a vein graft, or this was a very complex, PCI like multi-vessel PCI, and if this is a young patient, I know that the bleeding risk is low. In those cases, I would sit down with the patient, have a shared decision, discuss with him the advantages and disadvantages, and then decide. So in those selected cases, we do DAPT beyond a year, but you're absolutely right. In otherwise, we will not continue it beyond a year. Thank you.
Thank you, sir. Thank you. Now we are almost at the end of the session. Some quick remarks from our chairperson. May I request Professor G.M. Farooq sir to say a few words on this.
Actually, there are very high profile talking is going on over here. So there's already time is very much over. I think I must thank the participants from the abroad who has presented the cases very nicely. And my younger generation who practices this cardiology, I hope they'll learn a little bit more from them and wish them the good luck. Thank you very much.
Thank you, sir. Professor S.T. Ajum, sir. Sir.
Thank you. Thanks to all. This is the final. The time is very critical. Okay. Thank you very much.
Professor Mahbub Ali, sir.
Thank you very much. There are a few points I just wanted to say that I thought that the questions should come more from the attendees, from the junior and from the mid-level. But the questions were coming from the senior level. That's what was not expected. The senior should answer the questions, the junior should ask questions. You see, you shouldn't feel shy to ask a question, because the one who does the paper, he takes much pride in answering the question, number one. Number two, the moderator should be strong enough to stop over-questioning at the time factor. I think both of them are not strong enough. Number three, about asking too many shooting questions, I think we should go online. Like you should, and everybody can switch onto the online. You ask questions and they will answer it in course of time. But the time frame during every session is tailored. I think it should be, we should take it under consideration for the coming years to come. Thank you.
Thank you, sir.
Okay.
Professor Abdul Jai, sir.
Thank you, sir.
Sir, Professor Abdul Jai, sir. Professor.
আমাকে বলার জন্য ডাকার জন্য আমি ডক্টর আজমকে আমি ধন্যবাদ জানাচ্ছি। আমি সুখী হয়েছি যে প্রাইমারি পিসিআই এখন আস্তে আস্তে আমাদের দেশে পপুলারাইজ হইতেছে এবং সিনিয়ররা জুনিয়ররা এটা করতেছে। যে কমপ্লিকেশনের জন্য চিন্তা করে এই প্রাইমারি পিসিআইকে ডেফার করা উচিত নয়। এবং আমি বলবো যে যখনই প্রাইমারি পিসিআই হবে, দেয়ার শুড বি ওয়ান পারসন সিনিয়র মোস্ট to give opinion regarding the complicated cases and complex cases, so that the junior person can come out very successfully. And আমি আশা করে আমাদের এই প্রাইমারি পিসিআই উত্তরোত্তর আরও বৃদ্ধি পাবে এবং এটা আরও পপুলারাইজ হবে এই বলে আমি শেষ করছি। থ্যাংক ইউ ভেরি মাচ।
Now, may I request Professor Dr. Mir Jamaluddin for takeaways in a brief. He will say the takeaways of this session.
Thank you for giving me the opportunity. I am grateful to Dr. Azam as because he has arranged this nice program. But I have to tell few words by 1 or 2 minutes. From Shandip, from the speech of Shandip, we have learned how to do primary PCI even in bifurcation calcified lesion. For younger colleagues, I must have to say that don't be afraid of a calcified lesion or a bifurcation lesion in primary PCI in your hand, as because you are doing the primary PCI. And here Dr. Mahbub is there, who has the highest primary PCI in Bangladesh, so far I know. And you will never be afraid of primary PCI, whether it may be bifurcation. You must open the main vessel. If possible, reopen the side branch. If do not possible, forget about the side branch. At that moment, you should have to save parent. Then you will have to save the offspring. That is why I like to tell that don't be afraid. You will have to do. And if there is very much calcified, you are not able to do exactly the procedure what is necessary. Rota is not available in all center. At least you open the vessel. At least you give the TIMI-3 flow. Learn it. TIMI-3 flow is essential. If you can discover TIMI-3 flow, then after one day you send to another center what Dr. Shandip showed, and then Rota will be done. Then patient will be saved and much benefit will be obtained. And from Dr. Nasir Khan, that is the high thrombus burden. It is sometimes very difficult to overcome. For the younger colleagues, try to do it, even do it, if possible, with, though it is class 3 indication for thrombosuction, even then, sometimes it may be essential and you can do. And if only you get the landing zone, give the stent, otherwise not, mind it. And from MG Azam, multi-vessel, it is really a problem. Which one is culprit? Sometimes we get ambiguous lesion. Maybe RCA, is the culprit, maybe LED is the culprit. In that situation, to me, to do both the PCI of both the vessel is good. And what is my practice, also I do it. And STMI with cardiogenic shock, Dr. Chaudhary Hassan, this is really a challenging, as because we have not in our hand the assist devices. Mostly Impella is not available in our country. Only IABP is available in our country, and that is why it is very challenging. Even then, if possible, with the help of intra-aortic balloon pump, if it is in your center, you can do. Finally, I want to tell that all the speakers have given excellent speech, and they have shown very nicely their works, and we are grateful to them. Thank you all.
So, thank you, chairpersons, discussants, and the learned audience, and also the presenters. Now we are concluding the session.